All right, so what are we going to talk about today? Well, I'm not going to read it. You can see it in big bold. But we're going to focus on priorities, strategic priorities, and not just post-pandemic. It's kind of a little bit of a, it's a little short-sighted. We're obviously many years past it. So, but before we do that, let's do some quick introductions. You guys kind of heard my opening. I'm a healthcare VC. Entrepreneur turned healthcare VC, so for some of you entrepreneurs out there, it can happen. I did go over to the dark side, but before that I spent 15 years as an entrepreneur across 4 startups. Luckily, 3 idiots bought them, so I was like really excited about that. And then before that I spent time learning healthcare at the advisory board company. But I'll go ahead and get our panelists introduced. So Jesse, I'm up for you.
Well, good morning. It's great to be here. My name is Jesse Ehrenfeld. I'm a physician. I live in beautiful Milwaukee, Wisconsin, just up the street. I usually see patients on Mondays. I'm an anesthesiologist, and I am the immediate past president of the American Medical Association, where I've been on their board for 11 years. My research background's in informatics, digital health, AI, and I've been doing that work for about 20 years.
Okay, Angela.
Good morning. Angela Orsky. Can you tell I'm from South Carolina? So I work for Prisma Health, and I sit in a unique space. I have operations for all things that are in the home care space, and so whether it be everything from home health to EMS to care management, care coordination. But I also sit in our value-based care space, which is part of our clinically integrated network. So Prisma Health is the largest health system in South Carolina, recently expanded into Tennessee. We're about a $6.5 billion organization with 18 specialty hospitals, and there's a combination of over 5,000 physicians that are either employed or part of our clinically integrated network. So excited to talk to you today about some of the work that we've experienced and what we're looking at for the future.
And my name is Samson Magid. I'm the co-founder and CEO of HealthSnap. Started the company at the ripe age of 22 years old, right out of graduate school, and I've been building one of the largest virtual care management solutions for the last decade now. We partner with health systems like Prisma Health and others to help them start and scale virtual chronic disease management programs in the home. We do everything from remote patient monitoring to chronic care management and principal care management, and we have the full end-to-end solution from the actual EHR integrated virtual care management platform to device shipping and logistics for remote monitoring and the clinical staffing component as well. So we're really excited to be able to share more about our experience and the impact that we've made with programs like remote patient monitoring and chronic care management across the country.
Awesome, thanks guys for that. So let's get the easy one out of the way first, right? So, not that there's any hard questions, but so what has sort of stayed post-pandemic, right? So, and you guys remember on the screening call, I was kind of making fun of like, is it mask on? Is it mask off? Is it mask on? Is it mask off? I can't keep up. So Angela, I'm going to go to you first. Let's get the easy one out. Pandemic happens. What sort of has stayed in place? Like what sort of changed? And then it's like, hey, this is the new normal. We're not going to go back from this.
Yeah. It is mask on, mask off. But we'll say South Carolina was a little more liberal, so it was an interesting time for us. Our quick learnings have been flexibility and having versatility in how we engage with our patients. And so there is still a hardwired virtual component and a telehealth component for us. We quickly learned that our patients want multiple ways to engage with their providers. There's still some face-to-face. There is still a lot of patients who want to come in and have that physical interaction with their provider. But my daughter is a physician assistant in a specialty GI group, leads for our organization an inflammatory bowel disease specialty program. She has a lot of patients who, for convenience, have found that for their work schedules or for transportation issues, that the convenience of having that virtual connection is important to them. We didn't have that as hardwired as we wanted it to be, and so we scaled quickly, found out we could do it. It was easily doable. Our patient population, regardless of age, wanted to connect, were able to connect through technology. And so we've been able to keep that a framework of what we're doing. We had started some efforts around remote patient monitoring. We've just blown that just out of the water relative to the scale from that perspective as well. So it's omni-channels for connections to our patients, and it's the hardwiring of practices, and then we'll talk hopefully a little bit later about the importance of Epic. I will say some of the limitations, if we want to speak transparently, that we're facing is that we would love to continue to scale some of these elements. Reimbursement is starting to become a challenge for us, and so hopefully we'll talk a little bit about what that impact is to us as well.
Jesse, how about you? You obviously are across the country and you talked to a lot of leaders. What do you sort of saw?
So look, when COVID arrived and we made the pivot to telehealth, because we had about 10 years of acceleration for where we had been. If you look at the trajectory of uptake, that has maintained. There's been a little bit of recession. Patients like it. Physicians like it, we want to maintain it. It doesn't work for everything. So figuring out how do we create sustainable models that integrate, that meet the need is really the challenge. While there are real policy problems. So, we keep extending the Medicare telehealth flexibilities. The last extension in February, March, for 6 months. Not permanent. So we still have these policy things looming out there that if you're going to build systems that need sustainable payment policies behind them without that certainty at the federal level or across payers, how do you do that? It's a challenge. I do think there are also gaps. So, we have been in the improving health outcome space for a long time, working a lot in prediabetes, hypertension, thinking about what role the AMA can play. It still is true today that in almost every state in the nation, 1/3 of adults have high blood pressure. Raise your hand if you're out there. Only half are controlled. Why is that? You don't need a fancy new injectable peptide to treat hypertension, right? The pills are cheap. Like, they're almost free. And yet it's all these systems problems. And they're amazing ways to get people to blood pressure goals. Remote patient monitoring, pharmacist-directed titration of medications, all the things that we know can actually work, they don't scale. So in my service area, I live in Milwaukee. We've got a couple of large health systems, the one where I work, and some friends across town. They all have these programs for hypertension management, remote patient monitoring. They've each got like 100 patients in them. Each. These are big health systems, millions of encounters a year. So that's the opportunity and the challenge that I see as we think about how do we reconfigure the system to meet the growing demand.
Yeah, and I'm going to pull on that thread of virtual care. So I just got back from the American Telemedicine Association conference. And so it's really interesting, Angela, you pointed this out, and you did too, Jesse, that virtual care sort of came. I remember I'm an advisor to them, and my phone was ringing off the hook from health systems asking me for, suggestions. And I was like, dude, I've been talking to you about this shit for like 10 years. Like, what happened? Oh, suddenly now you want to do it? So obviously, but then now we've sort of gone back to like a normalization of it, right? Where people, obviously we're humans, we need connection. Why are we all here in the room? Because we need to see each other. But before we sort of dive deeper, Samson, how about you from a technology, from a startup perspective, right? Let's not leave the startup, us entrepreneurs out on the cold here. Obviously, providers had to pivot. But two things I wanted to ask you. One is, you've been building this company, COVID happens, right? What did you guys have to do differently? And secondly, even just right after COVID, we also had the explosion of digital health at a national scale, right? With companies like Livongo and Omada and all these sites. How has that sort of impacted, how you guys are building?
Yep. Let me just take a step back first before we get to kind of COVID and post-COVID. First of all, I think it's really important just to emphasize what Jesse said about the chronic disease epidemic in our country. I think it's top of mind as everyone has heard some of the stats, but we're at a confluence right now where there's 11 million new Medicare age individuals, and 68% of them have 2 or more chronic conditions. So we have a math imbalance right now where the the demand is far outweighing the supply right now, and our ability to support and manage these individuals. When we started our company, our focus was on trying to bend the cost curve and ameliorate chronic disease, and we focus as engaging individuals in their lifestyle, their nutrition, their behaviors, and providing a personalized disease management solution similar to like the Omadas and Livongos of the world. In 2019, in Trump 1.0, when they created remote patient monitoring, they unbundled one CPT code into 3 and then expanded from there. We said, we didn't even realize it, but we're doing all this connected monitoring. We're doing remote patient monitoring, let's start building this for the health systems and the actual industry and start partnering. And I think that's a really important distinction to make between some of the larger players that have gone public and have now exited or going IPO now. They are working through very different channels. They're partnering with self-insured employers or payers. Our thesis from day one was to actually make a difference at a systemic level. You need to partner with the providers, which is very difficult to do. And so our focus was, how do we clinically integrate this? How do we ensure we don't disrupt clinician workflows? How do we prove the clinical ROI? And how do we prove the financial ROI? When COVID happened, we were at the right place at the right time with the right solution, and it just picked up. And I think we think of this in 3 phases of where we are right now post-COVID. Phase 1 was emergency preparedness, right? I think it was we have to do this now, and let's just partner with anyone in the space and just figure it out. And we need to provide services to patients that's delivered all the time. Phase 2, which is where I think we are now, we're in the trenches of it, is how do we scale these programs? Jess, you referenced 2 large health systems with only a couple hundred patients. We have over 150 million Americans that have at least one chronic disease. And these programs have been proven to lower the total cost of care and improve outcomes for chronic conditions. And yet we haven't been able to scale these programs. And we'll talk about that more why, I'm sure, on this panel. And so phase 2 is, how do we actually scale this? How do we ensure that it's adopted at the system level? And then phase 3, which is where I think we're starting to now see, is how do we make this equitable and sustainable long term? And I think that's where a lot of policy work is starting to come into play. Exactly a week ago, we announced a RPM coalition with 7 of our direct competitors because we recognize the value and impact of these programs for chronic conditions in our country. And on the current trajectory, they will be unsustainable in the long term, and they will not exist. And that is a lose-lose for everyone. And so I do think we're at a really important time right now in the industry and space, both at the state and federal level. And we have a lot of opportunity to ensure that this is sustained for the betterment of our generation, our parents, our grandparents, to ensure that we're providing the right care at the right time. For individuals that have these high-risk, high-cost chronic conditions.
It's also really important, and I'm not going to pick on any company, any vendor. Several have been named, some public, others not. But it's actually pretty bleak out there. So the Peterson Health Technology Institute, I don't know if anybody from there is here, you guys know them, they put out a pretty damning report of the diabetes prevention program space. Companies that are doing really well, making a lot of money, that have 0 clinical impact. That's not sustainable. So there's a disconnect. And so one thing that's really, really important to us at the AMA is how do we make sure that we have tools that actually work, that have evidence behind them, that aren't just generating returns for investors. I mean, we want you to make money, that's great, but we also want you to make America healthy. Like, we need to have those partnerships. And it's important as we think about, particularly, I know we're talking about AI, we can't be up here without talking about AI. What's the level of evidence that we need for these products and tools and algorithms, whether it's AI enabled or not, if they're going to be paid for? And nobody really has the answer to that question.
Yeah, no, and I want to pull that thread. This is great because you guys are just guiding the panel. I can just sit back. So let's sort of pivot into, I also feel like outside of that big word that I'm not going to mention it right now, okay? But we're also in the world of tech-enabled services, right? Tech-enabled services is sort of that building, ground that we're talking about, where providers and technology are sort of meeting together. So let's talk about what you just said, right? And I would love for Angela to answer this. Okay, so you have tech-enabled service, you have all this technology, you're doing RPM, chronic care management, all this sort of stuff. Then you've got enrollment, like Jesse, like you said, 100 patients, 200 patients. Angela, what do you think? Why is that not happening? And then from your organization perspective, what have you guys been doing differently to scale those? I'd love to hear from you about that.
We've served over 6,700 patients in our RPM program. I mean, in 3 years since our partnership?
Yeah.
The scalability of this is strongly hinged upon, I would say, maybe 3 things. First, we did a partnership. So, we tried this on our own. We have 50 patients enrolled. Couldn't scale it on our own. We didn't have the logistics capabilities. We didn't have the right technology. South Carolina is hugely rural, and so we had to also look at the capability of the technology itself. But the workflow for our physician providers was as significant of a challenge for us. We couldn't get the right Epic integration. We are a total Epic shop at Prisma Health. Every service line, whether it be in my space, home health or hospice, or in all of our hospitals, all of our physician practices, total Epic shop. Our commitment to that was we wanted to make the workflow very solid. Epic is not always the easiest for an integration, and we would have all kinds of vendors coming to the table saying, well, we have integration. You may have had ADT interfaces, but you didn't have Epic integration. HealthSnap was a partner that brought to the table for us that full integration. They had the tools, they had the capabilities, and when I say integration, it is a full workflow integration. We get our readings that sit directly into our EHR for our physicians, and HealthSnap worked with us to summarize that, so when the patient presents in, they're no longer coming in with that notebook or that napkin of all their readings, and you know, Jesse, you would know as a physician, there's no way to know what their average has been in the home setting. This capability has given us the opportunity for the physician to see averages and where their trends have been at home, so that low-cost medication administration is then effective. And so they're not just treating what they see in the office. And we can talk about some of our results where we have seen clinical outcomes and demonstrated improvement at home or while they're in the practice. But it's all right there. The flow is there, the interaction with the physician is there, and then the other larger component that we also have to complement is the care management component of it, because there's that human factor outside of just getting your results and being able to see those, that coaching, the mentoring, the calling them when their readings are up to say what's going on today has just scaled us to a level that our outcomes, the significance of our outcomes and the cost improvement that we're seeing is just mind-blowing. And again, it's the right partner with the right tools to help us scale to be able to achieve this. As a large integrated health system, we just didn't have the resources to focus on all of this ourselves and build it on our own. We had to bring in the right person to the table to help us do that. And Samson, I don't know if you've got anything you want to that I overlooked or compliment around how you think that has made us so successful in our partnership.
Well, I think as I was talking about before, partnering with the physicians and the actual users, I think for investors and for digital health companies as well, it's really complex, right? It's not B2B, it's not B2C, it's B2B to B2C. Who's paying, who's using, and who's the actual adopter are all different. And so you would really have to make sure that you're building your solution that appeases all of those components. And I think that's something that we were very thoughtful around from day one, but most importantly is driving clinical ROI, which is driving financial ROI. And when you have the clinical rigor, we have done peer-reviewed publications with Prisma Health. We've demonstrated total cost of care and reduction in utilization to the tune of 45% reduction in hospital admissions and readmissions, and statistically significant. And so when you start showing that, then you have long-term adoption and sustainability, and I think that's where we've been able to ensure that this is a systemic standard of care at Prisma Health and others.
Our physicians refuse to work outside of their Epic workflow. They're not going to go into another platform. I mean, the clicks with Epic are what they are, and without having that ease of integration, we could not get the adoption. We had to make it a very streamlined workflow for us to expand this to. We have 49 primary care practices and over 300 physicians who are participating, but the workflow is simple, if you will. And there was a revenue component of it as well, too, that could help us from the sustainability. I mean, we are able to bill for the codes. We weren't doing that before, so this enhanced our ability to support this model.
Yeah, I mean, I think one of the things maybe for my entrepreneurs, I'd love to sort of, you know, you're not going to get this directly from me, but what's the cheat code, right? Like cheat code to enable, you know, you to sort of have drive with your customers. And of course, you know, Samson, I know I have investments in the same in tech-enabled services. We are just obsessed around enrollment. It's all around enrollment. How are you enrolling? How are you activating? So, you know, from that cheat code mentality perspective, Angela, I think one of the things that sometimes entrepreneurs or providers don't realize is that the provider has to also play a major role. Right? Like, to your point, Jesse, tech can't solve everything. I can't just show up with an amazing product and be like, dude, why are you not using it? Like, I built it, you should come. So what, from an organizational perspective, did you have to sort of change, right? Because you got to bring the horse to the water, but then you got to make them drink it too.
Yeah.
So.
So we piloted it with actually, when it was our largest, we contemplated whether we should start with our largest practice or a smaller practice for a pilot. But we started with our largest internal medicine group that was well-versed in just outcomes, driven for outcomes, very focused on their patient panel. And they helped us build what the workflow should look like. They helped us build how they could see the information. They helped us build what the triage protocols would look like when you had a care management team. They were a seat at the table. I didn't come to the table, even though I may be a nurse by trade, I didn't bring my clinical hat to the table and say, this is how we're gonna roll it out. It had to be a partnership that was built with them. But again, I had to make the workflow easy. And then I had to bring them in from the clinical perspective. And of course, HealthSnap came to the table very highly engaged, always on site working with the physician to help solve for the problems. And then the logistics. I mean, it's easy. The practices are not having to touch these devices. They're sent directly from HealthSnap right to the home, work directly with the patient to make sure that they can test them. Again, I can't overemphasize the efficacy of the workflow and the impact back to the practices who are extremely busy. We all know post-COVID and what we've seen, we have over 600,000 lives in a value-based care model. The cost of care in like our ACO REACH and in our MSSP is just astronomical these days, and we're seeing it across the nation. I mean, you've heard what happened with CVS and their ACO initiative. We have to think about sort of that total cost of care opportunity for us and drive factors that will help our physicians be successful on that lens as well too, because that funds flow goes back to them as well. So they're looking at it from, have my patients be happy? We have like 90+% in our percentile ranking for patient satisfaction in our ambulatory practices. We have improvement in our total cost of care, and then we've got incredible patient outcomes. It's a win-win for them. Started small, and then the scale was easy from there because we had a good framework.
And you make the really important point that the workflow is so essential. And look, physicians have gotten hoisted on them a lot of bad tech. Mm-hmm. And I'm an informaticist. I love technology. I love electronic health records. But when we incentivize them through meaningful use, it was too fast, too soon with bad workflows. Mm-hmm. And unfortunately, a lot of physicians have PTSD from that. Said, this is going to make things easier, better, give you more time, and then you're sitting in your pajamas logging in through the VPN to finish your notes. Nobody likes that. So there's, I think, an excitement and enthusiasm to have these kinds of tech-enabled services that can really help, but I think people are appropriately cautious, and they're not willing to do extra work.
Oh, they would count the clicks. Oh, this is 5 more clicks for me. I mean, that's seriously, right. It is that, when PTSD is that important to
when
them.
I'm living in Epic and like, that's my source of truth. Like it or not, that's how I'm going to make money. So I got to know how many clicks it's going to take. Click to revenue, right? Click to my
revenue.
RSUs. Mm-hmm. So, okay, probably our last topic. Okay, so I'm going to go to the audience. Who can guess what our last topic is going to be? And you get this beautiful can of water. Anyone? AI, you're the winner. Great. Come up stage and get the, wow, that was shocking, right? Look, not only do we have to mention AI at a conference, forget it. It has to be on every session, every panel. So here we are, right, Jesse? We were talking about it offline. I mean, I've got like 20 questions listed here, so I don't think we're going to have time for me to go through all the questions. But, let's just start broadly, okay? And Angela, I'm going to pick on you again, okay? AI, what does it mean for your organization today? Like, where are you at with AI?
Yeah. It is a buzzword, but it is also, we hear it across all of our disciplines. And I'll give you some insights into some key things that we're doing, but governance has been the number one thing for us, and that's what our organization is led with. There has to be strong governance. Again, there has to be, what is the return on the investment? Is it, we have broken processes, and so we spend a lot of time on what we're rolling out is solving for those processy challenges. One of the products that we're using that our physicians are loving is a technology called a bridge, and it's a point of service technology where they turn on their phone. All of the dictation from the office visit is captured on the phone. It weeds out the, how was your grandchildren, how was your trip this summer? It's an 80% efficiency factor for capturing the history of present illness and the problem notes for the physician. It is all they're talking about is the game changer that it is made for them, that they can turn this on, no longer requiring scribes to be in the room. And we love scribes, but they're hard to find in the state of South Carolina. It's not a workforce that we have access to. And so they're able to use that technology to make life much more efficient for them. And also other technologies like our sepsis work, where we've got sweepers within Epic that is looking at quality and safety perspective. We've had a significant improvement in mortality because we've got 75 markers in Epic that's being flagged, and so we can do some Epic interventions in that space. It's quicker for the clinicians, and they can establish workflows around it. And then also looking again to the future is from a remote patient monitoring, what is some of that same AI technology that we can weave into either some of the decision making and or the efficiencies of the information that is coming to us on our roadmap. I mean, we've chosen not to do ChatGPT, but we offer Microsoft Copilot, and we also use in our interactions with our patients from a patient experience a lot of AI technology. So if the patient reaches out through MyChart, that we can scrub it and get them a response back very quickly versus waiting on an actual person. And Microsoft and Epic have been great partners in that space as well. But again, it's all integrated around Epic.
Yeah. I know you've been itching.
I can't help it. So, you know, Bill Gates is a smart man who says a lot of stupid things sometimes, and he recently said that, you know, we'll have a future where AI and robots replace doctors, and I think that's baloney. AI will upgrade us, and for the entrepreneurs out there, don't try to replace clinicians. Try to augment them and upgrade them and make them more effective. And there are a growing suite of clinical tools that are very much taking that approach and knocking it out of the park, and it's really exciting. 60% of US practices are using AI tools. We continue to survey the market to understand what our members and physicians are doing. There's a lot of enthusiasm. There's the kind of unsexy back-end office operations stuff that has administrative implications, makes people's lives easier, like the digital scribe space. And then there's the growing suite of clinical AI tools. They're small, right? But they're coming quickly. So radiology is about to be transformed. It's happening. You know, more than 1,000 U.S. hospitals now have automated systems for image interpretation. And it's not that these tools are replacing radiologists, but when you need something read quickly in the middle of the night and you don't have the specialized eyeballs, you can rely on a tool to help the clinical team make a decision and then confirm things. And so we're seeing augmentation of workflows, all sorts of exciting stuff happening. But I think the framework needs to be around how do we make sure that these tools are supporting our workers, making them more effective, boosting capacity, because we so desperately need it because we just don't have the workforce.
Yeah, and my biggest comment on that, and I love for you guys to chime in, and even Angela, you mentioned a lot of different areas. Another little sort of advice for our startups and also maybe our investors. Who owns AI at the health system? I mean, dude, it's like, you know, I'm doing it patient experience, I'm doing it here. So is it the chief innovation officer? Is it the CIO? Is it the CTO? Like, who owns AI strategy at a provider organization?
For us, it is a steering committee governance that has representation across the board, because again, what is the need of our clinicians? We lead with, and to your point, Jesse, we lead with no clinical diagnosis can occur from AI. That is 100% still sitting with our clinicians. And so there's some strong governance around that, but it is obviously led by our CIO, sort of top of the pyramid, but he has a team of folks that are engaging that across the board for evaluation, governance, clinical outcome.
So you haven't hired a chief of AI yet? Anybody look for
so my organization we're hiring a chief digital health officer and strong governance around it. That person will drive a lot of the activity that propagates across the organization. I think a lot of organizations are making that slight pivot as they're thinking about how do they use those CMIOs, their CIOs, to ensure that these tools get integrated. But one of the challenges that's out there is, of course, you know, some of those big EHR companies would love to be the platform that everything attaches to. Right. There are other visions of the reality of the future where the platform lives somewhere else. But no facility can implement 30 tools from 20 vendors at 10 million a pop.
Why not?
Because they don't have the money, because everybody's got single-digit margins, right? So, pick any of the health systems in Chicago, they're all single-digit margins. So they don't have the time, they don't have the capital to do these huge multi-million-dollar deployments, which, for some tools, that's what it takes, right? So we're going to have to move to this platform approach. That's when we'll get clinical AI at scale. And there's this tension in the marketplace right now that at some point will get resolved.
So Samson, from your perspective, right, and from a tech-enabled service perspective, startups out there too, what sort of the use of AI do you sort of see, right? So you've kind of been there before this craze has shown up, and now you have to sort of live in it. And I'm sure you get asked that all the time from potential customers, or, hey, what are you doing with AI? HealthSnap, what are you doing with AI? So here's your chance to answer it.
Awesome. Yeah, I think we think of this on a spectrum, right? And we have to match our expectations with the industry. If you heard from Angela, I think right now we're still very conservative in the actual utilization in a clinical setting for clinical intervention. And so we recognize that our roadmap had to start with administrative, repetitive, workflow-driven things that we could automate with AI first. A really simple use case that we have gone live with in the last year that has been extremely impactful is QA and compliance. We submitted almost 3 million clinical notes in the last 12 months. We went from 3% chart review to 100%. And we're actually ingesting call transcripts, the actual conversation, the duration of the call, and matching that to the documentation and what was in the encounter and how much time was submitted for remote monitoring or chronic care management. And that's something that is, again, top of mind not only for health systems, but for CMS when it comes to fraud, waste, and abuse, and making sure that we're not overutilizing these types of programs. And so our ability to do 100% review and actually flag, hey, this was a 2-minute call, but you documented 38 minutes, this is not adding up, we're gonna flag this and not actually submit it and catch it before it goes through. That's something that we have launched, and it's been adopted company-wide as our first use case. The second one is actually using agentic AI right now, and still non-clinical, but actually doing a lot of the patient outreach and activation components. So patient enrollment, 64% of calls to our Medicare patients go non-answered. So instead of having a human doing those first call, we're actually using conversational AI that's calling patients. We can use multi-accents, multi-language, and it's always on, it doesn't get sick. So it's calling patients, you would have no idea you're talking to an AI, and then based on a warm handoff if the patient wants to participate in our program, it's now handing off to an enrollment specialist. And so that's been really impactful for us. The third phase of what we're now looking at, and this just came out in the fee schedule this year, is programs like advanced primary care management. Different than remote monitoring and separate than that, but chronic care management that has a time component and it requires a licensed clinical staff member, which is really difficult to scale. Again, we're talking, across the largest companies in our space, maybe a couple 100,000 patients total versus, hundreds of millions of people that there's an opportunity for. CMS has taking a very hard stance to say this is a tech-enabled program and you can start using different AI solutions to engage with individuals for things like medication reminders or even phone calls through conversational AI. So that's our third phase of how we're thinking about this. It's not going to be diagnostic, it's not going to be interventional, but it will do all of the clinical outreach component and care coordination work that's human augmented most importantly. So if the person ever wants to speak to a nurse, there will be a nurse that's being able to work at the top of their license. And I think that's really important to Jesse's point. It's not going to replace a human, but it will augment 80% of the low to moderate administrative work and allow them to focus on the top 20% of the higher risk or higher cost population. And I do think that's where a lot of the operational leverage will unlock as there's policy in place to enable this at scale.
Yeah, and I call that AI inside, because you're a company, you have a solution, but you're using AI inside to drive your margins, better activation, better enrollment, better engagement. So before I go to my bonus question and I get in trouble with the boss, so what's the and Jesse, I'm going to start with you because you're the AI guru on stage right now. Give me some examples of misuse of AI. I'd like to hear where it's.
Prior authorization.
Oh, I didn't even get the question out before you answered it. All right.
Years,
So tell us more. What do you mean?
I hear there was a lively discussion of prior authorization yesterday that I missed. Sorry about that. But look, prior authorization is the #1 pain point for physicians. It used to be the electronic health record. That's now #2. Prior auth is #1. We know that there are a variety of automated tools, whether they're AI or not, remains to be seen, used by the payer community to make coverage decisions that we think is problematic. We know it's problematic. And at the same time, there are a lot of companies out there that are building AI tools to fight coverage decisions. And so we're building this whole tech stack that in my mind is completely needless when we ought to just get rid of the problem and begin with by reforming prioritization. So that's a place where we're seeing these tools built that can do a job when it's just not the right job that we ought to be doing.
Right. Angela, how about you? In your guys' discussion, your sort of compliance oversight committee, have you ever seen or sort of been like, oh no, that's going to be bad misuse of, it's going to be misuse of AI? Any examples that you've sort of seen out there?
Anything around clinical decision making. I mean, I think that's why the first thing we led with was a very strong policy around how we will or will not use AI, and the who has the rights to make those decisions from an organizational perspective. But we're seeing and hearing a lot of technologies that may have some of that diagnosis components of it that they're not listening to it and not looking at it, but there's certainly a slow approach or at least a very intense analysis of what does that mean and what would be the outcomes of that. I mean, our physicians are very protective, of course, of their patients, and of course they want the things that help them, if it's through radiology and an easier process to read, or to filter through, certainly something they're looking for, but they want to be that final decision maker in that clinical decision making and review.
And I'll tell you, the backstop there's going to be liability, right? So who's going to hold the bag when there's harm? Clinical AI decision is made, it's autonomous, and then there's an injury. Is the developer going to hold the bag? Is the clinician going to hold the bag? Is the system? I think actually that liability backstop will be maybe the thing that keeps the human in the loop when otherwise the technology may be expanded in ways that we would think is appropriate.
It's going to hold the bag. It's going to be like, remember Deal or No Deal? It's the guy sitting in the room without the,
well, and precedent hasn't been set yet, to your point. I mean, we don't know where our boundaries may or may not be because there is no precedent. The legislative rules, the governance around that still doesn't exist. And so I think that is a limiting factor for us around where we want to go until we know what the safe space is.
All right, so bonus question, there's just a very short answer. You can't use a previous response to answer this question. Okay, remember, no previous response to answer the question. What is the wildest misconception you have heard that AI or technology can solve in healthcare today? Wildest misconception that AI or technology can solve in healthcare today. So you can't use clinical decision. Did I stump them? Guys, yeah? Okay. We'll let you noodle on it. Okay.
I heard a dialogue around prognosticating when you may or may not die. Now, whether that's, technology's there to do that, but some AI that would take your disease progression and potentially indicate when, that's a hard thing to diagnose from a clinical perspective, but there was conversations around what could that look like and could you take that whole panel and a lot of ethical concerns around what that could generate for sure.
I think what we see, especially in the care management space, and we talk to a lot of vendors that try to sell us their intelligence inside the solution that's and they're using it's AI risk stratification and AI scoring. I think the biggest misconception is that providers actually don't want that. I don't think they know what to do with that. They don't know what to do with that, and it actually doesn't enable better care if you're risk stratifying populations. They want evidence-based care pathways that have established protocols that it can be generated. So if I said, this person's temperature is above 102, that doesn't really mean much. But if I said they had a fever with this symptom, there's an evidence-based protocol that the provider then knows how to follow. So I think that's a big misconception where technologists are trying to build all these risk stratifying solutions for companies like ours are just bringing that to market. But if the physicians don't know what to do with the data, they're not going to, one, use it, and two, it will actually add administrative burden. So I think that's a really big misconception that we see a lot.
Well, and to your point, I think that's what has driven, we only have sepsis as our current model where we're using those markers in Epic, but the key components of that are it becomes a flag and then the clinician is then engaged and triggered in order to do a clinical assessment, and then there's a well-defined workflow or clinical pathway that is partnered or associated with that.
Okay. All right. Well, Jesse still has to answer that question, but he can answer it after the panel. You can come find him. All right, let's go to questions from the audience. See, I made sure to leave some time. Okay. All right.
Hi. So in talking about some of the challenges of people bringing up AI in clinical decision making, I talked to a lot of digital health startups who like to argue that what they're developing is not a medical device. It's a clinical decision-making tool. And I said, okay, well, what do you think a diagnostic is, according to the FDA? So there's still a lot of uncertainty surrounding how these types of products would be regulated. Yeah. What types of clarity would you really like to see come out of that?
I mean, look, nobody wants to be a medical device in that space because then they have a regulatory framework that's more challenging, right? But at the same time, whether you're in the regulated or unregulated space, the fundamental question is, what's the level of evidence that ought to be required for something to be brought into the marketplace? And I don't know the answer to that. And the previous administration was hell-bent on this post-market surveillance sort of thing, and that may be the right approach because, like, who could the FDA ever hire enough product reviewers to look at every software change? Like, no, certainly not today. After a lot of the agencies not there anymore. So if you're not going to do some pre-testing or an assurance lab frameworks, which we don't think makes sense, we don't think that that's feasible. Then you're sort of left with post-market surveillance, and we just don't have the interoperability across systems to do that at scale across the nation. So again, we're sort of stuck, I think, scratching our heads trying to understand what should that level of evidence be.
Thank you. Great panel. Thank you for all your expert insights. Question, I guess, specifically for Angela, though, of course, would welcome others' expertise. Working with technology to enable remote patient monitoring that has a really compelling use case for cardiology and heart failure patients. And I come from the MedTech world where we always think about orienting around the clinical champion with the technology to advance patient care. Thinking about commercializing this technology, would it make more sense to start from kind of a top-down perspective, start with the health network and the value-based care champions, or more start from a bottom-up perspective that I'm used to, start with the clinician and let them champion the technology throughout the system?
Great question. I'll tell you how we found success. I mean, each organization is going to have sort of its own flow. Our physicians have had a lot of energy around the technology and talked to a lot of vendors. We're inundated all the time around just, companies that are reaching out. We found the best success where we developed the strategy at the health system level around this is what we want to solve for, and then brought in our clinicians to be our stakeholders in the conversation. And then we drove the work. We didn't leave the responsibility to them. And so, again, we couldn't do it on our own. We had to bring in a partner like HealthSnap who had that strategic plan for us. They completely operationalized what the rollout would be. And so even on my side, I was named the champion of this work under that other duties is assigned, which was a great gift retrospectively. But I needed a partner who could help me walk along that journey that I didn't have to own it all myself. I wasn't the subject matter expert. So in that flow, it was beautiful in the big scope.
And I'll add something to that. So a little cheat code for you. I've invested in that space. I've invested in the tech-enabled space from a cardiology perspective. What we found where our startups had success was we said, look, you're looking at these big old health systems, right? You got to have a long-term strategy. You got to have a short-term strategy. Cardiologists are actually probably one of the most innovative physicians out there. They love tech.
Right behind anesthesiologists.
Well, yeah, of course. Sorry, Jesse. But so we said, okay, short run, go to your cardiology practices, right? And even if you're going to a health system level, look, even if you land at a health system level, to your point, like Angela's, they're going to sit there and say, all right, well, first thing we're going to do is we're going to clinically validate this, right? So if you're going to go approach a health system, go find the cardiologist champions in that community, right? Go get them to be like, yo, I love this. So when you're going to the health system, they're also hearing it from their users, their adopters. And so we found that to be a great intersection, right? Where business and clinical sort of meet together. So you gotta do grassroots. It's hard, right? Finding those clinicians in the arena. Yes, and you're gonna have some of them that are just gonna be like, oh my God, this is great, and they're gonna try to, and the venture innovation folks are like, oh God, here comes, Dr. So-and-so talking about he loves this. But I think it's a good strategy to sort of use a champion, use a clinical champion, especially if you're really clinically focused from that perspective.
Okay, I got a question for Jesse
the
and
boss.
Angela. So you guys started this conversation with chronic disease management, but the way our system is set up right now, we're treating stuff very downstream. I think Bobby Kennedy is a little nuts, but I do give him props for taking on the food industry. Wouldn't he have a lot of help if organizations like AMA and providers actually got behind the idea of holding food companies accountable?
I mean, we underinvest in prevention. There are lots of things that we know would support health and prevention of disease, including things related to food consumption, what's in the products. I mean, my husband only buys bread from our local bakery that has no preservatives in it, and we throw it out every 3 days because it gets moldy, and we buy no bread. That's a decision. It's a very active decision. That's not a decision that most Americans make, right? So there definitely is something there. We look for those opportunities to align sort of our policy goals to improve health outcomes by investing in prevention through a whole variety of means, and certainly there are things on the food side that would help.
Yeah, and I think I'm just going to add to this because you and I have talked about this offline. Our U.S. healthcare system is a reactive system. We're not a prediction-based, prevention-based system because the financial instruments don't do that, right? There's not a lot of payers out there who are going to sit there and say, oh yeah, I'll pay for a prediction score, right? We should be living life like that, but unfortunately our financial systems and our healthcare systems don't let us do that. So there's a lot of technology being built out there that even we see, and I'm like, this is amazing, it's fascinating. Who gonna pay for it?
And if the incentives get flipped because of a change in federal priorities, there'll be a completely different opportunity for entrepreneurs and companies to enter into that space to help us, which would be, I think, actually quite exciting.
I mean, you saw the CMMI's last statement was making America healthy again. And so, you research that, and Stamps and I spent a lot of time talking about what does that look like. I mean, reimbursement now is for the chronic piece. We've got to move that upstream, and there's technology to support that.
I think we're making meaningful progress, though, because a lot of people think about primary prevention, right? Like all of us, if you don't have a chronic condition, you don't want to have the first one, but you can't pay for something that doesn't exist. But it's really important to call out that people that have in a rising risk population, if they have hypertension as their first diagnosis, they're most likely going to have a secondary and a tertiary morbidity diagnosed to them in the next decade. And so the secondary, not only secondary prevention of the condition itself from a congestive heart failure, but we can actually intervene with individuals from dietary strategies and lifestyle strategies when they're initially diagnosed. And I do think that's where technology and solutions like remote monitoring, chronic care management come into play, because you can materially, one, either reverse and or slow down the cost curve at that point.
All right, any more, or should we stop? One more? Okay, last question.
Thank you for the conversation. So continuing on where you left about where we spend so little on prevention and where we are looking at less than 5% investment in primary care, how do you see health systems really prioritizing chronic disease management that takes 80% of our budgets? RPM definitely has a place for it, but when you look at a disease like obesity or diabetes that is chronic, which means you have a long-term care, and where primary care really doesn't have bandwidth to do it, where do you see health systems investing in expanding care teams, engaging, creating digital engagement with patients, so we're empowering more of that care back to the patient? Where do you see that going?
I mean, we need to do it. The challenge I think that I heard on my left is the sustainability of the models and the care teams to actually make that effective and engage patients in those cares. So yeah, patient with diabetes, how do we get them onto a pathway in a program that enables them to have the best possible health outcomes? That's a challenge, right? We know what to do. We just have a real hard time getting people on the pathway, engaging them in the pathway, keeping them on the pathway, and ultimately reducing the burden of things downstream. I do think there's a tremendous opportunity for the AI tools and the services, digital connected, to support that, whether it's just on the engagement, just in keeping people on the pathway, or doing other things around it that right now, unfortunately, we don't do the things that we know matter.
Agree. We have a lot of omni-channels. We can do a lot of outreach. We have a platform now where every patient leaving our hospital, every patient leaving our ED, we can narrow it by diagnosis, and we can have very intentional scripted questions that are sent out to the patient, and it's easy for them to respond. It's sent by text messaging. We get like 80% response every time we send it out. So we reach hundreds of thousands of patients on an annual basis. But to your point, it's when they hit that level of long-term management that we struggle with. What are their resources and their ability? I look forward to the technology, whether it be virtual AI, where there is that, where they have access to more resources that are very specific and prescripted to them versus just very generic. And I think we can be able to get some development around that. We'll be very successful.
Yeah, and last point, primary care is going through an evolution too, right? So last few years, when you sort of saw primary care come under the focus, it was large, venture-backed companies that were very focused on it from an employer perspective, employee perspective, or direct perspective. And we saw some of that stuff kind of implode. So I think now is the time for the health system, for the providers to sort of partner, right, with the employer, with those organizations to sort of really focus on primary care. Because I think, they're the gateway, right? They're going to flow to a lot of different organizations. And I think their best use is to actually adopt technology, but the problem begins with, well, who's going to pay for it? Yeah. So I think, again, there's got to be a lot of regulatory work that's going to go after that to sort of incentivize these primary care physicians to sort of start that conversation, right? Be it diabetes, obesity management, whatever it may be. So, okay, I think we're going to get the hook.
Okay.
Yes? No?
Yeah.
Okay. All right. Thank you, guys.
Thanks, everybody.